Good morning, everyone. Welcome to today's webinar resident series, Digital Dentistry 2.0. This lecture is being presented by Kelly Bevington, and now it's my extreme pleasure to introduce Adam Dreyfus, the Director of University Government Institution. Take it away, Adam.
Good morning, Nicole, and thank you so much for the warm welcome. So thank you so much for joining us, and we just really appreciate your time and your support of these courses. As I always say, NDX is here for you today, tomorrow, and for the future, and that does not go without a doubt for how we all feel on this call today. These courses are here for you to learn, for you to interact, and for you to ask your questions. And if you're not comfortable asking your questions, please reach out to any of us on this call at any time, and we'll be more than happy to get you the information that you might be inquiring about. But this call isn't about me or Bianca. It is about our esteemed speaker this morning, who is a knowledge base of digital dentistry and so much more. Without further ado, Kelly Bevington, please take it away.
Thanks, Adam. Thanks, Nicole. Hi, Bianca. Thank you so much for joining us this morning. We're going to talk about digital dentistry, about intraoral scanning, and where things are going. So feel free to ask any questions in the chat. Get going here. So we're going to specifically talk about tips for evaluating and confirming an accurate bite registration. Can't tell you how important it is and how frequently we as a laboratory receive bite registrations that are not accurate. We're going to touch on implant scanning of scan bodies, reviewing different types of fully and partially edentulous scans, and review the fact that the anatomy that is acquired in a digital scan is the same as what you would acquire in a physical impression when it comes to dentures, when it comes to removables. So this is me. I'm Kelly. I am a full-time employee of National Dentex and not financially supported by any other companies. This is my current training team. So we are able to support really the East Coast, the Midwest, and the West with clinical dental professionals, either RDAs, CDAs, or registered dental hygienists are here to support your needs. And what we typically work on is really focusing on restorative scanning basics, how to acquire the best scan possible, tips on edentulous scanning and scanning for implants. This is a document that is available to everyone with some little helpful items specific to scanning for crowns, isolation, and managing tissue. And let's talk a little bit about why we would want to go digitally. So it improves the patient experience. I can't tell you how strongly I can say that now. 10 years ago, it was good, but it was still sort of cumbersome. Today, the patients are truly wowed by the technology. There are so many wonderful patient education modules within every intraoral scanner system that allows you as a clinician to communicate about their oral health in a way that makes sense to the layperson, right? It's not by showing them an x-ray and trying to explain to them where the decay is or an open margin on a crown. It's pictures that make sense to the patient. The accuracy of digital impressions is phenomenal. As a laboratory, we measure redos or remakes, cases that come back in because they did not fit appropriately. So much fewer remake cases from digital scans, digital impressions versus analog. So with analog, it's closer to like 5%. With digital, we're more at like 2.5 to 3%. So pretty, almost in half. Once you become proficient, it really is much easier to take a digital scan than a physical scan. It allows you additional time to do other dental procedures, and long term, it will save you on overhead, right? Not day one, right? Because you've got the cost of the machine. We all realize that. But long term, and once you become efficient at scanning, and as a laboratory, I work for the lab. I do not work for a intraoral scanner company. I will never tell you to throw out your alginate or your PVS material. There are times and places where that still makes the most sense. I like the scan because I was the person at the 5 to 15 before I felt comfortable and confident in scanning. I find that the younger folks oftentimes pick up scanning seamlessly, instantly. And I think it's that hand-eye screen technology that they have all grown up with. Being an over 55 person, I did not grow up with screen technology. So that whole hand-eye screen mesh in my brain was a little more challenging. And I certainly find that with a lot of folks, over the age of 55. So we as a company receive over 3,500 scans every day, and there are new scanners coming up all the time. I would say our primary scans come from iTero, Trios, Medit, Prime Scan, Dexis, Emerald, Shining 3D. There's just more and more every day. So that's exciting to me and everyone in the digital dentistry world. So I like this particular slide. It was from the NADL, and it's the digital versus traditional. But what I liked about it is that 58% of clients who have an intraoral scanner has increased over this past year. And it's up 53% since 2022. So I know it's a year or two old from research stance, but what a huge difference after COVID in people introducing intraoral scanning, digital impressioning. And what can we scan for? So I'll tell you, I first started scanning approximately 18 years ago. And at that time, the only thing that particular scanner could scan for was a single unit crown. And that was it. And then it migrated, and you could do a full arch scan of complete dentition for an appliance, orthodontic aligners or a bruxism appliance, something along those lines. But today, truly, we can take a digital impression, an intraoral scan for anything that you would take a PVS impression for, including surgical fields for all-on-X cases. I mean, it's really amazing. The technology, the changes that the research and development teams have made are just superior, and they are going to increasingly get better year over year. I anticipate that still within my lifetime, we're going to see ultrasound technology as an intraoral scanner. It's not there yet. But someday that camera will be able to look through saliva, blood, and tissue, but it's not there yet. So we still need to make sure that we are creating a clear, dry field as well. So I think it's really important that when you're considering going digital, that you identify why. Why is it important to you? Are you technology driven? What type of files might you need? And I state that because that is what's really becoming a big thing today. Is if there's intention to be printing models on site, or fabricating like a printed bruxism appliance on site, or provisionals in your office, that file need is going to be different perhaps than what you would need and be required to send to a laboratory. And then, of course, I am always a huge proponent of demonstrations. It's really important that you get that wand in your hand, that you touch it, you feel it, you experience it. If you could scan on a live person, that would be fantastic. But even if it's a typodont model, I think it's really worth your time and investment to do so. So a couple examples of different scanners and what they look like. So this is iTero from Align Technologies. And then we have the Trios from 3Shape. And notice most companies today have many different platforms, right? So they typically have at least 3 different platforms choices for you. And it's often derived by a good, better, best sort of scenario as far as what you want to be able to use the scanner for. And in regards to portability. So most all companies now have some sort of a laptop version that allows you to take the scanner from one office location to another, as well as carts. And then there's that middle of the road scanner that is typically the workhorse for everyday scanning crowns, bridges, implant crowns. And then there might be an upgraded version that is specifically geared and better at scanning the fully edentulous intraoral tissues. So just know that. Go through. So these aren't necessarily meant to be answered, but if you care to identify your answer in the chat, I'll certainly take a peek at it. But I'm always curious, like, are you currently using an intraoral scanner? And then if so, to my next page, what device might you be using, right? And these are just a few choices, if you will. And then who within the practice is currently doing the majority of the practice, or of the scanning rather. I find that every scanner today now has a workflow that allows an auxiliary to take a maxillary scan, a mandibular scan, and a bite registration scan prior to doctor even anesthetizing the patient, but certainly prior to cutting a prep. And then doctor can scan in the prep itself and everything else is done. So that's a really, really nice workflow. And what are we scanning for, right? Again, knowing that we can scan for crowns, implants, dentures, aligners, all on 4, all on 6 cases. I think it's well worth your while to have certain standing operating procedures for each of these so that whoever is going to be doing the scanning feels really confident in the order in which they need to acquire the different scans. So it's where are you, right? Where are you with your digital journey? I know my digital journey, again, started 18 years ago. It has continued to evolve. Yours will continue to evolve, and know that we're here to support you as a beginner, or boost confidence, or really get you to that next level of scanning wherever you may be. So let's talk a little bit about the actual workflow in the traditional digital laboratory workflow versus digital. So the iOS department, if you will receive the file very similarly than if we received a PVS impression. And at that time, the file is going to be articulated, margins are going to be marked, bite registrations are going to be double checked, and the case will be virtually mounted. Very similarly as if a PVS impression came into the lab, into the model room. All systems out there today are very accurate. They provide a enhanced visualization for the laboratory technician that is working with your scans. And it also allows us in many cases to do a model-free restoration. Typically, they're single unit posterior full contour zirconias, but know that that is a potential option for you. So examples of that portal I mentioned, you know, the virtual mounting department, and then of course marking those margins. And notice when I'm showing the images that they are in monochrome, they are in stone model. Most all software that dental labs are using for design are them seeing everything in monochrome. They still have access to the color scans that they can toggle back and forth, but the design part itself is in that stone model mode, or monochrome, we call it. Every scanner out there on the market has the ability for you as the clinician chairside to review your scan in monochrome. And I highly recommend that you do that. It gives you a slightly different visual. It's easy as clinical dental professionals for us to know the difference between enamel, dentin, and gingival tissue when it's in color, right? Like it's clear as day. But when we change it to monochrome, you know, sometimes that margin does not look as crisp as we thought it was. And the distinction between the gingival tissue of the sulcus and the finish line of your prep can be a little blurry. It can be sort of fuzzed out. So it's important for you to take a peek at that. Again, the designers start with a particular library that they are able to build in with your restoration design based off the morphology of the tooth that they are working on. CAD CAM, you know, CAM is the computer aided milling, whereas CAD is the computer aided design. We also do a tremendous amount of printing as well. Lots of different manufacturers, lots of different options with materials. The finalization of that crown is still very similar to what you would see with an analog fabrication of a crown. It's still characterized, it's still stained and glazed. That final QC still exists. And we talk about, you know, why do we want to go digital? It really has a lot to do with the patient and how they perceive the office, the experience. I like to share a story of my husband who changed dentist right after COVID, and the new dentist had an intraoral scanner. The previous dentist did not. He went in. The first procedure that was done was a scan of his mouth. He then had some x-rays done. The hygienist cleaned his teeth, and the dentist came in for the exam, you know, talked about the exam, and then brought up that scan that was taken, you know, as soon as he walked in the door. And they were able to clearly communicate to him the need for a crown on number 14 by illustrating, right, what the tooth looked like, not just a single tooth like an intraoral photo, but his entire mouth articulated, and identified the first molar and said, you know, do you see the gray area there? That's an amalgam. Do you see the black line through it? That's a fracture. We're going to recommend a crown to help preserve the health of that tooth. And his comment was that his previous dentist has been telling him for a couple years he needed a crown on that tooth. And he even showed him an x-ray, but that really didn't mean anything to my husband, who's a helicopter mechanic. So know that communication tool is there with every intraoral scanner on the market. Anything that you have in your practice right now, you could easily use it to communicate to your patient about their oral health needs. Lots of hygienists love to use it just for a quick scan. Could be the lingual, the lower anterior, where there's calculus buildup. They'll take a before scan and then an after scan right after they clean the patient's teeth and show them that before and after. And it's like, hey, the after is what I want you to look like 6 months from now when you come back. So that's sort of fun too. And it's all about building that roadmap, right? And how you want to utilize the technology, creating different procedures. As a lab partner, we're here to assist you with that as needed. I find that many practices, many offices today are really identifying a particular individual at the practice, at the facility, at the clinic that is in charge of the scanner. I call it the digital champion, and they are the person that is responsible for communications with the labs, for software updates that are required for the scanners. Many scanners out there require software updates that need to be done regularly. And they're also in charge of the verbiage for patient engagement and communication. Why is that important to your practice? There's lots of different items that different scanners have on them that you can select from. And knowing what's important to you and what the future of scanning might look like to you personally helps aid in making the decision about what type of a scanner you might be interested in or learning more about. So let's go to that bite registration we were talking about. I said I wanted to make sure that we confirm what type of bite is inaccurate or not. So you'll see this is an iTero scan, and you'll see that the bite registration is a bit of a wave on the buccal. So I would say the most important thing that many clinicians fail in acquiring is enough gingival tissue on the buccal surfaces of the teeth. So every scanner needs approximately 2 to 4 millimeters of gingival tissue below or above the CEJ. It assists the software when merging the maxillary and mandibular scans together. Oftentimes, the clinician goes too far distally in beginning the acquisition of that scan. So they really need to start more up in the premolar area. It does not have to include the prep tooth. It can, but it doesn't have to. And so when you start sort of where the teeth interdigitate and immediately go to the maxillary arch, capturing that 2 to 4 millimeters of gingival tissue, and then to the mandibular arch doing the same, it has the maxillary and mandibular arches merge together more effectively. The only scanner that is a bit of a caveat with that is the Planmeca Emeralds. And for those scanners, you want to make sure that you're only starting on one arch so that the camera only sees the maxillary teeth or the mandibular teeth to begin when you first turn the wand on, and then you will migrate to the opposing arch. I like this as far as what's acceptable or what's not acceptable. Just to sort of reiterate visually, right? Not going the whole way posteriorly when initiating the scan is really important, and that's a very common error that people make. If you think about it, I mean, it's just not comfortable to the patient. The other thing to remember is to sit your patient completely forward. Not, I mean, you know, it could be at a 90-degree angle, but what I want you to avoid is having them upside down on their head where they've been for the last 20 minutes while you've been cutting a prep, right? Because I just feel very strongly that it's a disservice to the patient for us to ask them to close normally when they're upside down and they're numb and we're sticking something in their mouth, right? So sit them up, rub their condyles a little bit, have them practice opening and closing, then explain that you're going to place the wand in their mouth and ask them to close normally. If you're not able to do that preoperative workflow that I mentioned earlier, this is your next best option. And it's just because the maxillary and mandibular arches merge together does not mean that the bite registration is accurate. Okay. Like we can take a blue moose bite, just because we take it doesn't mean it's correct. So it's the same sort of thing with the digital impression. It's still up to us as the dental professionals to confirm that the bite registration is accurate. So you can do that by flipping it and looking at it from the lingual. That's probably my favorite way of doing it. And then that way you can ensure that the cuff tips are interdigitating appropriately as well. And then most all scanners today also have software that will identify where the patient is occluding. And if they're only occluding in one specific area, excuse me, that could indicate that the bite registration is off. The nice thing is it's super easy to delete it and take another one. Very, very simple, very quick. Now, this is the same sort of thing, except with Trios. And I've identified Trios and iTero because that's the scanners that we personally receive the most scans from. So with Trios, in addition to what I just discussed, you also have an option to manually set that bite registration. And there are different scanners. Plan Mecca, I know, can do a manual set. Not all scanners can. It's becoming a more popular feature within the scanners. And I would say the lab has had pretty equal results as to whether doctor has manually set the bite or if it has physically come together within that scanned image. So when you're manually setting a bite, it's always going to be a triangle of some sort, right? So these dots that you see here is you're taking it from one arch to the other, and then the same thing on the lower to allow those images to merge together. Again, still, it's up to us to identify its accuracy. So let's talk a little bit about implants and scanning for scan bodies. Something we're doing more and more and more of. I'm not going to go into great detail here. You all know what an implant crown is and whether it's cement or screw retained, but it's really important for you to identify that to the laboratory, whether that be in the notes or from a drop down on the prescription itself. And the more information you can provide to us, certainly the better. There's never too much communication. In many cases, you can upload different CBCT scans or photographs or surgical report to the case itself that you are sending, right? Like from the scanner or from the desktop computer that you might be sending the scan from. And in other cases, they aren't being sent together. It might be a separate email with this additional information, but please note on the RX that you are sending an additional email with more information. So the lab can be on the lookout for it and make sure that that email info gets married together with the actual clinical scans. So what is a scan body? A scan body takes the place of what we know or knew as an impression post that we would use for an open or closed tray impression. So this center image is the scan body itself. There are many, many different types of scan bodies out there. Notice each scan body identified here on the page has some unique identifier to it. So it's either a slant, the occlusal surface might have a specific angle to it. It could be a divot, it could be a dimple. They're referred to as key identifiers. And when placing the scan body intraorally, you want to do your best to place that key identifier facing buccally. It will make the initial acquisition, the initial pickup of that scan body a little easier, just a little easier for you. If you want the entire case to be OEM, original equipment manufacturing, then you want to make sure that your scan body matches the implant that's in the bone, and you will ask the laboratory for an OEM workflow, right? That will be for your custom abutment. It's also very important to take a radiograph of the scan body when it's in place. You want to make sure that you are communicating to the lab who the implant manufacturer is, like what's in the bone, right? What type of scan body it is you're using, the platform size, and of course, what type of a custom abutment and what type of crown do you want? Specifically letting us know if you want that cement or screw retained. And one other thing with the scan bodies I want to mention is if you have multiple scan bodies in a row, you want to alternate them. So let's say you had 3 in the anterior. You would do the first one with that key identifier buccally, the second one with the key identifier, let's say, faced more mesially, and then the third one with it faced more distally. And you just want to tweak it a little bit. And the reason for that is, the computers, AI, everything is super, super smart, right? But we're still a little bit smarter. What happens frequently with the scanners is it sees the scan body as a part. And if all 3 of those are identical, it picks up the one, and then it doesn't want to pick up the second and third scan body because it perceives that it has already acquired that data. And yes, I learned that the hard way. It was very frustrating. So I like to share that information with people. We talked about the importance of taking a radiograph. I mean, truly, that's the foundation of everything we're doing right now. Every scanner out there also has the ability for you to take some sort of a preoperative scan, a pre-order scan. They might call them something a little bit different. It could be called a tissue scan in some cases. And truly, that's what it is. So it is a scan of the gingival tissue at the implant site without the healing abutment, without that healing cap in place, and without the scan body, taking an image of that gingival tissue and the adjacent interproximal contact walls of those adjacent teeth as a separate scan. And the value in that, especially in the aesthetic zone, in the anteriors, is it allows the lab technician now to have that gingival tissue scan when designing a beautiful emergence profile for that crown. It's really, really important, again, especially in the anterior, but in the posterior as well. It helps to alleviate some of that black triangle effect from a crown that isn't designed to appear very naturally growing out of the tissue itself. Please also note that when the scan body is in place, it is almost impossible to capture a bite registration scan. So just don't think that you can. Usually you will not be able to. So don't be in a habit of trying to do that. Some radiographs of those implant cases. This is called the ENCODE, and it is from ZimV. They are now pink. They used to be silver. They're really super cool. They're typically placed by the surgeon, and it allows the user to not have to use an additional scan body. So this is the healing abutment, the healing cap, and the scan body all rolled into one. And the name by ZimV is ENCODE. I know Straumann just launched their own type of ENCODE, as well as Nobel, I believe, and Vista. And why they are so nifty is because of this coating. So again, it is the scan body and the healing abutment all rolled into one. So you don't have to remove this to take that final impression, to take that scan. What these lines and divots are on the occlusal surface of the scan body is a specific code. And so when it is received at the laboratory, we decode it and we're able to identify what type of implant and scan body, platform size, the whole 9 yards is there. I like this particular image because it shows the difference between these two images. Now, we, as a laboratory, this ended up being a remake crown, and the reasoning for it was not seated the same both times, right? So the second time, the one to the right, it was seated accurately. That's part of the importance of taking a radiograph as well. Excuse me. As I already mentioned, you do want to remove that scan body prior to taking the bite scan. 9 times out of 10, the occlusal height of that scan body will not permit the patient to close properly. Every scanner RX is going to have a slightly different options for you in filling out the RX itself. Now, this one happens to be iTero. You will see the pre-treatment scan box right above the apex of number 3. I got it. Go here. That becomes your tissue scan. So that is what you would want to make sure you click in order to have that pre-treatment scan when doing an implant restoration. And so now it is checked. It also allows you to select what type of an implant abutment and what type of scan body you have. As well as the manufacturer. Lots of different options. So it's what's in the bone and what type of scan body, because of course they don't have to be the same. If you want it to be OEM, it needs to be the same. So just know that that's an option for you. And then a little bit about what you want in the abutment and what you want in the crown itself. And again, most all scanners have this level of detail when working on the RX itself. and specific workflows for that. So this is an example with the pre-treatment. Pre-treatment is always going to be the first scan. And in Atero's case, it is a green background as pre-treatment versus the operative is always going to be blue. Sure if you can hear that or not. It sounded pretty light. It's really just reiterating what I said about doing the pre-treatment scan first. And then at the end, you want to make sure that your digital dye, if you will, is fully encompassing the scan body. You want to make sure that the entire scan body is captured in that view. And here's another good example of that. And then this is it in the monochrome that I mentioned, right? So some examples of good gingival tissue scans. These are pre-treatment scans. And then the scan body scan. So again, the pre-treatment scan is a gingival tissue. And then these are with the scan bodies. Most every scanner company has some different guides, some standing operating procedures for specific procedures. And typically implants is one of those procedures. And it's a great thing to have that available as a quick reference when you're new to scanning for implants. With trios, there's different trim and lock features that allow you to take that preoperative scan that we mentioned earlier. And identify the custom abutment materials and so forth. Different drop-down menus. I love drop-down menus. Anything that has a picture, it can make it a little easier. So there will be 4 different steps, right? The upper, the scan body itself, the opposing, and then the bite registration. This is an example of the acquisition of, excuse me, of the emergence profile scan. You're able to mark that particular tooth. We're locking this information. And then we'll be able to scan the scan body afterwards. And so this is a secondary option where you can scan with that healing abutment in place. And then it has a cutout tool, a trim tool to remove the scan body. And then you will scan over that for additional emergence profile information. Which that one is probably my favorite because with some patients, the tissue collapses very, very quickly. And you want to just have to take the healing abutment out for a very short period of time. This is scanning the actual scan body, always starting on that occlusal surface and then rotating buccally. Super. And then scanning that opposing. And notice, for demonstration purposes here, this was all done with quadrants. In today's technology, truly, there's no reason to not do full arch scans, specifically with implant cases. I think there's great value in doing that. It takes literally, 20 seconds more, maybe, to acquire the rest of the arch. And when it comes to final occlusion, I think it's worth that investment of time. So let's finish off here with some removable prosthetics. Identifying, again, I mentioned earlier that the anatomy that you would be required to capture with an analog impression does not change for a digital impression. So the retromolar pad, the maxillary tuberosity, the hamular notch, the buccal vestibular muscles all need to be captured with a digital impression as well. That can be a little challenging at times. However, as the technology continues to evolve, it becomes easier and easier to do so. And the accuracy, this is an example of an accuracy test that was done with CAD/CAM dentistry versus a traditional pack and press of a denture was far superior. Love, love, love scanning for immediate dentures. It's just the best. Most scanners scan off topography, meaning the lumps and bumps of the oral tissue, so it loves dentition. When scanning teeth for an immediate denture, it works out really, really well. You just want to make sure that you get that buccal vestibular muscle. On the lower, make sure you get that retromolar pad. And on the maxillary arch, make sure you get posteriorly enough to capture the vibrating line and the maxillary tuberosities, the hamular notch. Those are going to be key points. Some examples of good positive scans that will be used for an immediate dentures. Some examples of what is not adequate. And these are real life cases that come in. So the buccal vestibular muscles, the vestibules, were not adequately captured in order for us to make a removable prosthesis. In general, there are 3 different workflows when it comes to removables, and that's a copy denture, a reference denture, and an immediate. So we talked a little bit about immediates, love immediates. Copy denture, super easy. That is truly a copy of what the patient already has. So it's the patient coming in saying, I have this denture, I love it, I'm going to be traveling this winter for the next 4 months, and I would just feel better if I had a backup, if I had a spare, an extra. And so you're able to now, with all of the scanners out there, I never want to say all, with most all of the scanners, because one will pop up tomorrow that I'm not familiar with, but most all of the scanners provide you with a workflow and the capability to scan an actual denture, both the cameo, the tooth surfaces, and the intaglio of that denture. But what we see the most of is really a reference denture. And so these are some different examples from the RX. And most all scanners out there are going to give you options, right? What do you want next from that scan that you took? Do you want a custom tray? Do you want a bite rim, a try-in, or do you want to go directly to finish? I'm never going to recommend to go directly to finish. However, a bite rim, I think, can oftentimes be great versus a custom tray, because you can take a wash impression inside of that bite rim, and I'll refer to that then as digitally assisted. So it's not 100% digital, but it gives you the option to also capture a physical impression in the event you need to. And if the patient doesn't already have existing dentures, it can be a very nice workflow to use, because you're acquiring the intraoral impression and verifying vertical with the bite rim, with the wax of the base plate, all in one session. And you could either scan that, or you could put it in a box, send it to the lab, and then the lab can either provide you back a functional try-in, or, and the functional try-in is printed, or a traditional wax try-in. Again, regular mold, shade. Talked a little bit about the reference denture, and these are some follow-up imagery to go with it. It's important to make sure that denture is cleaned on the inside, and that you use tray adhesive on the intaglio surface of the denture before placing the impression material. It helps the material to stick. The thing that I really like about this workflow, and this is the border molding section. So heavy body first, then it's going to be a light body wash, and then the bite registration. So the thing I like about this workflow is, after you scan this, you peel out the impression material and provide that to your patient. So they're not the impression material, but their dentures. You provide their dentures back to the patient. And the patients love it, because ordinarily they're without their dentures for a few days, and that can oftentimes prevent them from accepting that treatment. So really, really like that workflow. Dr. Thompson sticks, really like these when scanning the fully edentulous intraoral cavity, especially on the maxilla. I would not necessarily use it like this, but I would put a few X's at the vibrating line, so I know how far posteriorly to go. When you're in the midst of scanning, sometimes all that pink gingival tissue stitching together on the screen can be a little cumbersome, right? It can be a little challenging to decide which direction to go. So if I have a couple X's at the vibrating line, and I might even start at the rugae and do like one straight line and a T, sort of an upside down T, straight back to the vibrating line, it can be very, very helpful. And remembering those anatomical landmarks. And with that, I am going to conclude.